Good morning, everybody. Thank you for the organizer for this kind invitation to be here in this night meeting. And particularly, I would like to acknowledge Vanessa this kind invitation to talk about which parameters must be checked in order to avoid thrombotic complications in CDG patients. I'm sorry to say that unfortunately now we are not able to firmly answer this question. But now we are doing some research, and I'm going to show you the data that we have in our lab. And we have now some clues and some approaches that could help to in a near future, help to answer this question. What we are going to see in this talk is, first of all, a general view of the hemostatic system. Secondly, the most recent results of this system in CDG patients. And finally, a protocol to manage vascular complication in CDG patients that has been made from in Barcelona in the Sant Joan de Déu Hospital. So first of all, during thousands of years of evolution, higher organisms with a very high pressure circulatory system have developed a very complex mechanisms in order to avoid the fatal consequences of the bleed. The hemostasia is maintained by a simple mechanism that is composed by few elements. The platelets that play a role very important, and secondly, few plasma proteins that are in the circulatory system that cause a quick and immediate response able to avoid the bleeding and form a clot in the vascular damage. When the vascular damage exposes the connective tissue that is in the platelets surface and in other adhesive, and it also is release other adhesive molecules, and it causes the platelet adhesion and the platelet activation. And this activation also recruits other platelets, forming the platelet plaque. Simultaneously, there are some procoagulant surfaces in the platelets and in the endothelial cells and in the monocytes that trigger the coagulation cascade, that trigger the extrinsic pathway of the coagulation cascade, and finally activating high amounts of prothrombin to thrombin, and the thrombin activate the fibrinogen to fibrin, forming the fibrin clots that also traps other blood cells and avoid, in this simple and very quick response, the consequences of the fatal bleeding. But these mechanisms has also to be very well regulated, and in space and in time. And this regulation is caused by two main elements: the anticoagulants, that the main anticoagulant in the organisms are the antithrombin, the protein C, and the TFPI, and the fibrinolytic elements. So, in general, the hemostatic system is a very well-balanced equilibrium between procoagulant elements and anticoagulant elements, and maintain the blood flowing, but also is ready to act and in vascular damage. So, but this normal hemostasia could also is sensitive, very sensitive to even minor changes in this balance. So there are two sides in this of the coin in this equilibrium that could have pathological consequences. If we have deficiencies in the anticoagulant elements or different variants of procoagulant elements, this could lead to a high risk of thrombosis. And on the other hand, if we have deficiency of procoagulant proteins like factor 8 or factor 9, or low levels of platelets, that is thrombopenia, we have a very high risk of bleeding. So now, how is the hemostatic system in CDG patients? We cannot forget that all plasma coagulation factors are N-glycoproteins, and the platelets contains surface proteins highly glycosylated. And despite N-glycosylation is involved in very biological processes like immunogenicity, specificity to interaction, the sensitivity to protease, or the half-life and stability of each protein, the effect of an impairment in the N-glycosylation in each protein could be very different. In other words, in this experiment that we have performed, we have removed N-glycans in two different anticoagulant proteins, antithrombin and TFPI, and the effects of this removement is different. As you can see here, in the antithrombin is more sensitive to this removement of N-glycans, and the release of this protein to the conditioned medium is lower if we cut these N-glycans. But this effect is not so evident or so important in TFPI, as you can see here, and both are anticoagulant elements, very important in our organism. So now what happened with the hemostatic proteins in CDG patients? We have reviewed in the literature all the data about the hemostatic proteins of PMN to CDG, and also we have evaluated our cohort of 20 patients, 19 PMN to CDG and 1 ALG 12 CDG. Around 100 patients in total from the review and from our lab. And in the literature, we saw that in most of PMN to CDG have anticoagulant deficiency, and the most important anticoagulant elements are severely reduced, as antithrombin, protein S, or protein C. And this also occurs with one procoagulant element, the factor 11. In 58% of cases, it is also very reduced, severely reduced. In our hands, in our lab, we have confirmed these results. We have 20 patients, and as you can see here in this slide, we have a very severe deficiency in antithrombin, protein S, and protein C, and also in factor 11, this procoagulant element. And something that was very remarkable was that we, for the first time, identified the TFPI deficiency in these patients. And it also is very severe, as you can see here in two representative patients. So with this view, we could see that anticoagulant side of the hemostatic balance is severely affected. So it seems that in this patient could have a very high risk of thrombosis. And in experimental mice models, there is a mice that is very resistant to have thrombosis, and here in this work, they reduce the levels of two anticoagulant, protein C and antithrombin, to levels around 10%. And in these mice, produce spontaneously and very quick thrombosis. In our cohort of 20 patients, we have 3 of them with very reduced levels of these 3 anticoagulants, antithrombin, protein S, and TFPI, below 20%. And one of them, as you can see here, all these 3 anticoagulants have levels below 16%, and it was very, very remarkable because they do not have thrombosis so far. So we wonder why it is like that. We cannot forget the important role of the factor 11. Factor 11 deficiency was first described as hemophilia C in 1953. And this deficiency does not produce severe hemorrhages. In contrast, factor 11 deficiency induced in animals antithrombotic effects in arterial or venous models without compromising the hemostasis. Moreover, congenital factor 11 deficiency is protective against ischemic stroke and venous thrombosis. And finally, reducing factor 11 levels in patients undergoing elective primary unilateral total knee arthroplasty was an effective antithrombotic method and appeared to be safe with respect to the risk of bleeding. And we have observed that in our 20 patients, 53% of them have factor 11 deficiency with levels below 50% and with a mean factor 11 in total of 53%. And in these three cases that were very affected in the anticoagulant side of the hemostasia, we observed that also have very low levels of factor 11. So we think that it could be a compensatory mechanism why and this could be the reason why they don't have thrombosis. Indeed, there is an excellent correlation between antithrombin, factor 11, and TFPI, and between TFPI and factor 11. And also an inverse correlation between hypoglycosylation, measured as allosteric and antithrombin factor 11 or TFPI. In other words, when the disorder is severe, the deficiency of antithrombin or the factor 11 is also severe. So what do we have in the hemostasia of CDG? Comparing with a healthy subject, we think that they have a relatively balanced equilibrium between anticoagulant and procoagulant elements. Maybe a little bit disbalanced because of these reduced anticoagulant elements. But they have. But it's important to say that all the proteins, procoagulant and anticoagulants, are reduced comparing with healthy subject. So this balance could be more susceptible to even minor changes. And also we think that that the ratio antithrombin factor 11 could be a very good. Could be very useful to measure the risk of thrombosis and should be also evaluated in further studies. And now what about the usefulness of global hemostatic test in CDG? Many people question the usefulness of this test to prevent risk of thrombosis, and also we do. Because this global test, probably reflect the capacity of the hemostatic system to respond to a procoagulant stimulus, but not the risk of thrombosis in each patient. The best example in these cases is the APTT, that is prolonged in most of cases in 76%, and in all our patients had a prolonged APTT, which suggests that they have a very high risk of bleeding. But we have seen that there is no association between an APTT and with the risk of bleeding in CDG. And we also performed thromboelastography or thrombin generation with the same results. This global test suggested a very high risk of bleeding, but we see that this is not in correlation with the clinical findings. Because as you can see here, the vascular events that we have reviewed from the literature and from our cohort is that 60% of cases have bleeding, but we have seen that the thrombotic problems are more frequent in CDG than the bleeding. If we test platelets, that is, as we have seen before, other elements important in the control of the hemostasia, we could see that these patients have normal platelet count and normal size, and normal platelet reactivity against all agonists. And also we also observed that platelet and glycoproteins are neither quantitatively nor qualitatively significant affected. And of course, we have other thrombophilic factors that could contribute to this risk of thrombosis. And we cannot forget the severe thrombophilias. But severe thrombophilias are very rare, like antithrombin deficiency or other deficiency. So, there are also other common but mild prothrombotic polymorphisms that could be evaluated in these patients, because these polymorphisms increase, as you can see in this table, the risk of thrombosis. And as far as we know, there are no studies evaluating these prothrombotic polymorphisms in the severely affected the hemostatic system of CDG. In our 20 patients, only one patient carried a prothrombotic polymorphism, the factor V laden, but these patients had no thrombotic events so far. And finally, I would like to show you a protocol for the management of vascular complication in CDG patients that was performed by Dr. Pérez Dueñas in the Hospital San Joan de Déu. If you have some, this is the protocol that they have carried out. If you have some, if you like to say, if you want to have more information, you could ask Dr. Pérez Dueñas. And now we are carried out more experiments and more studies, and what it could be very useful to study patients with thrombosis and to evaluate these samples of these patients in the acute moment of the thrombosis, in order to see what is going on in this specific moment. And is what we would like to do in the next months and next years. And now I would like to acknowledge all the professionals that have collaborated with us. And of course, I would like to acknowledge you for your attention, and to all the patients and their families for their great collaboration. Thank you.